My name is Dennis Gable. I'm the global PI for thoracic for the GREAT study. This was a registry study that was started by WL Gore back in 2010. This is a study that is a real-world evaluation of use of Gore aortic products in the abdomen and chest, or in the thoracic aorta. This is a multicenter study that includes 113 centers over 14 countries and 4 continents. The study is slated for 10 years of follow-up, and we've enrolled nearly 5,000 patients total. 578 of those patients are included in the thoracic cohort. One of the strengths of this study, and physicians that would look at this, is going to be the fact that it is a real-world study, and it is all comers that have thoracic pathology. That's what we're after on this particular study. We're looking at patients that are treated for aortic pathology. Now, that pathology may include aneurysm disease, it may include dissection, intramural hematoma, aortic penetrating ulcer. This study has just completed the 5-year follow-up, and that has just been published in the Journal of Vascular Surgery. This is now providing the long-term follow-up that we did not have before, and that's the importance of doing this study. Additionally, the study is a real-world event. In other words, it is not just at academic centers, it is not just by people that do large volumes of care. It is achieved by multiple people, some in large academic centers, some in community practice, some that have high volumes, some that have moderate volumes of care with endovascular thoracic grafts or endovascular abdominal grafts. But this allows us to see what the real world outcomes are with everybody being treated. So I think there's several items that belong in the key data that I would consider important. Probably the biggest one is if you look at the follow-up that was achieved in this study for 578 patients being identified for the thoracic aortic component. We had a follow-up of over 95% in general for all patients. Now, in looking at that along comparable registries, that is significantly strong. And that also gives validity to the other data or other key components that we can talk about. One of those being that the overall rate freedom from aortic-related mortality is just under 95%. So these patients, which we saw an all-cause mortality of just over 66%, these patients, fortunately, are not succumbing to issues related to their aorta after they've been treated with these devices, but most of them are succumbing to other unrelated issues. We also see that with this, we have very low rates of reintervention, low rates of spinal cord ischemia, low rates of stroke. You have one stent graft with migration, which was a stent that was landed in the aortic arch. You have no compression and no stent fracture that is noted throughout all patients. And again, these are patients that a fair number of them anyway had imaging through the 5-year window. We don't have any significant difference in comparison of the outcomes of this device and this study to other printed or peer-reviewed journal articles that are out there demonstrating that this device can be deployed. All of these outcomes that we see have been achieved despite the fact that nearly 44% of all patients were done off-label. Now remember, this is a registry study, and so naturally some of these are going to be done with sizing discrepancies or landing zones that would not be acceptable within the IFU. Since this is a registry, the enrollment was left up to the discretion of the provider or the physician. These were all patients treated with the WL Gore C-TAG device. With that in mind, outcomes were strong despite the fact that nearly 44% were treated off-label, which I think owes to the real-world component of this, showing that we can still achieve good outcomes even though it's not exactly as printed or suggested by the IFU. I think one of the advantages of the conformable thoracic stent graft is just that. It's conformable. It matches into the anatomy. I've had several patients personally that have a very tight arch or significant tortuosity throughout the thoracic aorta. And I've been able to achieve, with the use of this graft, good apposition of the wall, easy or relatively easy ability to pass the device into the position of deployment over the wire. It's very conformable not only in deployment, but it's conformable going up over the device or over the wire to the point where you're going to deploy it. The second part of that is that when you do have someone with a Gothic arch or tight arch, you're able to deploy that with good apposition of the wall, good conformability before the graft is fully deployed, which will allow, again, for good apposition without much bird beak, if any at all, which is one thing we don't want to have, but allow good flow without stenosis, without pinching or anything like that down the graft, so you have good flow through the end of the graft.